Hello and good morning or afternoon. My name is Tracy Cook and I'm with Sachs Healthcare Communications. We'd like to welcome everyone to today's webinar, and I'd like to show our audience today how to send in your questions, which our speaker will answer as many as possible at the end of the webinar. Please just type your questions into the questions box. Our moderator for today is Christina Davis. Christina is currently an adjunct professor of United States University in San Diego, California, and Aspen University in Denver, Colorado. Christina has an extensive background in GI, digestive disorders, in both the treatment and diagnosis of GI and liver disorders. Her background includes clinical research through the NIH and FDA on the infection-related topics. Christina, welcome.
Hi, Tracy. Thank you for that very kind introduction. The title of today's webinar is Diagnosis and Management of Small Bowel Bleeding. Speaking today on this very important topic is a leading expert in the field, Dr. Daniel Rains. Dr. Rains is Chief of Gastroenterology and an Associate Professor of Clinical Medicine, G. Gordon McCarty, MD and Dowd Chair in Gastroenterology at LSU Health. Dr. Rains provides instruction to fellows in clinical gastroenterology with a focus in small bowel disease. His research in small bowel disease has resulted in a specialty expertise in small bowel capsule endoscopy and balloon enteroscopy. His recent publications include a textbook of capsule endoscopy and small bowel disease titled Capsule Endoscopy by Case Study, which has been adopted by American College of Gastroenterology. The speaker has disclosed the following financial relationships, which is Medtronic. And in order to get continuing education, it's approved for 1 AMA Category 1 credit for physicians. You'll go to a link at the end of the presentation, and you will be able to obtain your certificate after the webinar is finished. Below is the accreditation statement. And in order to obtain continuing education for nurses, it's been approved for 1 contact hour for nurses as well. A link to obtain your certificate will be available at the end of the webinar. The accreditation statement is below, and support for this activity has been provided by Medtronic. And I will go ahead and pass it over to Dr. Rains. Thank you.
All right, good afternoon. It's a pleasure to be here, and I appreciate this invitation to speak on this topic, which is actually my favorite topic, diagnosis and management of small bowel bleeding. After I graduated from fellowship in 2007, I've spent most of my practice managing patients with small bowel disease, and my practice is primarily composed of video capsule endoscopy and balloon enteroscopy to examine the small bowel for bleeding sources and other pathology. So this is a topic that's near and dear to me, and this is where I spend the majority of my time, is managing patients with this diagnosis. I'm going to stop the webcam for a minute so we can focus on the slides, and we'll resume after for the discussion, for the comments. So the objectives today are to define suspected small bowel bleeding, including description of likely bleeding sources in patients in 2 groups, those under the age of 50 and those older than the age of 50. So likely pathologies are different in these 2 groups, and management is somewhat different. The second objective is to review currently available technologies for evaluation of suspected small bowel bleeding, and in that we'll reference guideline recommendations from the three major societies. And then we'll discuss management of challenging cases of suspected small bowel bleeding in which initial diagnostic testing is unrevealing. So first is definitions. So prior to 2015, we defined obscure GI bleeding as GI bleeding which is undefined in source after negative EGD colonoscopy and small bowel follow-through, and that accounted for about 5% of all bleeding. This has been updated. So since 2015, we call this suspected small bowel bleeding because patients with a negative EGD and colonoscopy, most of them have a small bowel bleeding source. So in patients with suspected small bowel bleeding with a negative EGD colonoscopy, most of those will have a likely bleeding source identified on video capsule endoscopy. And of those with a negative video capsule endoscopy, many will have lesions on CT enterography or other studies which are revealing for the source, so it's not really obscure or unknown. So instead of 5% of bleeding, maybe 1 or 2% of all GI bleeding is obscure or unknown.
So when we see patients with obscure GI bleeding, then there's 2 types. There's overt, which is patients that bleed grossly. They come to the emergency room or to clinic with a complaint of melanohermatochezia. And then the other group are patients with occult bleeding, where they have intermittent or chronic bleeding with heme-positive stool and or iron deficiency anemia. Those that present with a complaint of fatigue or headache or chest pain or shortness of breath. And there's a big difference in presentation and a big difference in likely pathologies based on these two different patterns. So often I'll characterize patients with overt obscure bleeding or overt occult bleeding. For the standard bleeding evaluation, this is a guideline recommendation from 2016, which is similar across other society guidelines. Typically, patients with iron deficiency anemia that's unexplained should have an upper endoscopy and colonoscopy unless recently performed, and typically within the last year. EGD should include biopsies for celiac disease if possible, and colonoscopy should include examination of the terminal ileum to look for Crohn's disease. If these are unrevealing, then video capsule endoscopy is definitely next. And then there's a deviation based on the patient's age and also the patient's response to iron therapy. If patients are over the age of 50 and their anemia resolves with oral iron therapy, then the treatment is observation only. And these patients or this patient population, angiectasias are common, and the patient may have one or more small angiectasias with intermittent bleeding. They don't need any other testing. You might be somewhat uncomfortable with the concept of a bleeding source that's not diagnosed, but you should get comfortable with that because that's most common. And we generally manage these patients expectantly. About 2/3 or maybe even half of these patients will come back with recurrent anemia. And if they do, then they need repeated testing with either repeat EGD colonoscopy, repeat video capsule, or CT enterography. The other population is patients that have progressive anemia after video capsule. They get additional testing such as CT enterography or device-assisted enteroscopy. And also patients that are younger than age 50 should proceed down this algorithm on the right. Patients younger than age 50 don't have angiectasias. They're fairly rare except in patients with HHT. And so they need additional testing. They have something unusual. They have Crohn's disease or insane enteropathy or a Meckel's or a tumor or some other diagnosis. So a patient younger than age 50 that has obscure GI bleeding really needs a fairly extensive workup. And then bleeding after negative EGD colon, about 25% of those patients have lesions that are missed by EGD colonoscopy, and those include Cameron's erosions, GAVE, peptic ulcers, vascular ectasias, namely angiectasias or doulofoil lesions, and flat neoplasms. And then small bowel bleeding sources can make up about 75% of bleeding sources just after negative EGD colon, not necessarily negative EGD colon video capsule. Often when we do video capsule endoscopy, we are finding sources that are within reach of upper endoscopy, such as Cameron's erosions, angiectasias in the duodenum. So if you don't do video capsule endoscopy or the patient is not a candidate for some reason, then push enteroscopy would be a reasonable next step to look for these missed lesions or subtle lesions. But because most of these patients have small bowel bleeding sources, then video capsule is the standard of care after negative EGD colon. As far as small bowel bleeding sources, most of these patients have vascular ectasias or angiectasias, and that includes doulofoil lesions and angiectasias. And then other patients have ulcerative diseases such as insane enteropathy or small bowel Crohn's or Meckel's. And then finally, tumors. And there's 4 tumors of the small bowel that we see commonly: carcinoid tumor, gastrointestinal stromal tumor, adenocarcinoma, and lymphoma. I'm going to spend a minute on angiectasias. So angiectasias are age-related degenerative vascular lesions. And when I say age-related, they typically occur in patients over 50, more like 55. They're fairly rare in patients younger than age 50 unless they have Osler-Weber-Rendow syndrome or hereditary hemorrhagic telangiectasia. There's different names for these lesions. They're called angiodysplasias, which I tend not to use because it assumes that there's a dysplastic or progression to like a neoplasm, which is not what happens. They're also called arteriovenous malformations or AVMs, which I also do not really use because not all angiectasias have a true arteriovenous connection. Most patients, again, are over the age of 50, and therapy includes endoscopic ablation, iron supplementation, and therapy with octreotide. There's some other agents that we use, but octreotide is generally the standard of care. Sometimes we forget about iron supplementation and octreotide therapy in this patient population. and assume that endoscopic ablation is kind of the only intervention. But aggressive iron supplementation will often manage these patients as effectively as as endoscopic ablation. So for patients with suspected small bowel bleeding, you have 4 tools that we can discuss: small bowel follow-through, video capsule, multiphase CT or MRE, and then device-assisted enteroscopy. You may have one or all of these resources available at your institution, and your use of these may vary based on the availability of these. For small bowel follow-through, that was previously a standard test after negative EGD colon, but we don't use this anymore. The diagnostic yield in suspected small bowel bleeding is extremely low. It's very rare for a small bowel follow-through to pick up pathology such as tumors or anything else. It's not very sensitive, it's somewhat cumbersome, and it's just not used anymore. So we no longer use small bowel follow-through, either small bowel follow-through or small bowel follow-through with enterocolysis for evaluation of small bowel bleeding. If you're still ordering this test, you should probably stop ordering this test. I rarely order these, and it's rarely or never for suspected small bowel bleeding. So this is an outdated test. Video capsule endoscopy is a standard test. It was FDA approved in the US in 2001, and now it's widely used. This is a video capsule system that takes pictures of the small intestine, or really the whole GI tract, in 2 images per second, or now ranging from 2 to 6 images per second. And it's diagnostic for a bleeding source in patients with negative EGD colon, and about 60%, or the diagnostic range is quoted as 40 to 70% in patients with suspected small bowel bleeding. On the right, you can see a picture of the papilla or ampulla at the top, and on the bottom, we can see Crohn's disease. As far as society guideline recommendations for the use of video capsule, all 3 major societies recommend video capsule after negative upper and lower endoscopy for the evaluation of iron deficiency anemia and suspected small bowel bleeding, or overt bleeding with suspected small bowel bleeding. So that is the standard of care, and that's practiced primarily, really all over the country for patients with negative EGD colon and GI bleeding. There are some additional recommendations from these guidelines. The AGA notes that early use of video capsule endoscopy may allow for a more rapid diagnosis as well as increased diagnostic yield. And typically that's in 2 different studies. One is video capsule study within 3 days, increases diagnostic yield and decreases hospital stay for inpatients. And then outpatient video capsule within 14 days increases diagnostic yield from 60% versus 30% greater than 14 days. So when you use a video capsule in the hospital, you're going to find the bleeding source more often and decrease hospital length of stay. When you have outpatients that have video capsule and they're discharged from the hospital, you'd like to do their study within 14 days to improve diagnostic yield. The ACG notes that barium studies should not be performed in the evaluation of suspected small bowel bleeding, which I'd agree with, and that is congruent with the ASGE guideline as well. Now, what do we do after negative video capsule? The risk of rebleeding after a negative video capsule is 35 to 47% over the next 2 years, and this is in patients greater than age 50 with potential small bowel angiectasias. If their hemoglobin drops by 4 grams per deciliter, or if they convert to overt bleeding, they need additional testing, and that additional testing is going to be tailored to the patient and their specific presentation. They may have a repeat EGD, or a colonoscopy, or a video capsule, or a CTE, or a double balloon, kind of all depending on their presentation, but they have repeat testing until we find the source or they stop bleeding. With video capsule, there is concern in the community sometimes about risk of missing something significant like a tumor. That's very rare. Small bowel tumors are rare as sources of bleeding. And even in my practice, I rarely find small bowel tumors. Most of these patients have angiectasias unless they're under age 50. Capsule endoscopy can gloss over a submucosal tumor, such as a gastrointestinal stromal tumor or a submucosal carcinoid tumor, in about 19% of cases of tumors. But overall, capsule endoscopy is diagnostic, and the risk of tumor is relatively low because the prevalence is so low, and then 81% are captured by the video capsule. In patients younger than age 50, additional testing is indicated as angiectasias are rare. So again, patients with a negative EGD colon video capsule that are younger than age 50 have something rare or unusual, or kind of a strange explanation or a potentially more serious explanation for the cause of their anemia, and they need additional testing. As far as multiphase CT, this is really a different CAT scan than you're used to ordering. You can do a multiphase CT with a standard CAT scanner. It's just the protocol is different. So we're using 2.5 millimeter slices instead of 5 millimeter slices, and then also we're doing axial, coronal, and sagittal reconstructions. We give IV contrast with this, and then I give isotonic oral fluid to expand the small bowel, and that's usually milk, a half gallon of milk. And this study is highly sensitive for small bowel tumors, but that's in research settings. When the radiologist gets paid for this exam, they get paid for reading a standard CT scan, the abdomen and pelvis, which has something like 200 images, but this has thousands of images because of all the different reconstructions in 4 different phases. Then, it takes a long time to read. So often you'll get a reproduction of a study or a study that doesn't quite compare to what's done in research trials, because in research trials, they're doing a very detailed study in multi-phases with very experienced physicians to identify tumors such as the small carcinoid tumor we see here that enhances with IV contrast. But in the community setting, this does not necessarily translate because the studies aren't performed exactly the same and they don't have the same expert. But it's still a good study, and it's obviously low risk. So this is an important slide. What do I do in patients that have a negative EGD colon and video capsule? What do I do with that patient? So these are the interventions. First is we're going to review some additional questions with the patient. Next, we may consider deep enteroscopy, and that includes push enteroscopy, which many of you can do. And then you can do second look video capsule or repeat video capsule, just like you can do a repeat upper endoscopy or colonoscopy. And then finally, you can proceed to provocative testing, which is what I do in my practice because I have such complex cases. So this is an important slide, and you may want to note some of the ideas that are listed here and incorporate these ideas into your practice for evaluation of these patients. When patients have had a negative EGD colonoscopy and a negative video capsule and say a negative CTE, some of these questions may lead you to a diagnosis that's revealing for them. So the first question is, do they have a personal history of epistaxis requiring evaluation by otolaryngology or ENT? If they do, then a diagnosis of HHT is more likely, which is not a rare disease. Second is radiation exposure. So patients with a history of external beam abdominal radiation for cervical cancer or testicular cancer may have radiation enteritis as the source of their chronic GI blood loss. And sometimes you have to ask the specific question. Third is blood donation. So I love this question because rarely, or maybe once every year or two, I will discover a case of iron deficiency anemia related to frequent blood donations. So some patients are used to giving blood, say, every month, and they've been doing it for 10 years, and now they have a diagnosis of iron deficiency anemia that is unexplained. And the explanation is that they donate blood every month. The other reason I like blood donation as a history element is chronicity. So some people, they present with a new diagnosis of anemia at age 60, but then when they tried to donate blood when they were 40 years old, they were denied because they were anemic at that time. So blood donation helps with chronicity. The next is menorrhagia. So patients with abnormal uterine bleeding may have this as an explanation for anemia, and that's a question that should be asked in a patient that's, 40 or 45 that you might not ask in that patient instead of a patient that's, say, 25. AAA repair, patients with a history of AAA repair are at increased risk for aorta enteric fistula as an overt bleeding source, and so that's an important question. NSAID use is also very important because often patients get NSAID enteropathy or little breaks in the small bowel mucosa from NSAIDs. You have to ask the question in a bunch of different ways. So, do you take NSAIDs? The patient may say no. Do you take something to help you sleep? Yes. I take Advil PM to help me sleep. Do you take any arthritis medicine? No. But I do take goody powders multiple times a week for migraine headaches. So I ask in a bunch of different ways, anything over the counter, anything from any other symptoms, and any risk factors or indications for an NSAID like headaches or back pain or arthritis. So that's very important, and often that eludes us. Vitamin B12 deficiency is an interesting thing because it may be an indicator of a diagnosis of autoimmune multifocal atrophic gastritis, or MAG, or atrophic gastritis or type B gastritis. And these patients have atrophy of the gastric mucosa, and they have inadequate iron and B12 absorption with lack of acid production. So we check for antiparietal cell and anti-intrinsic factor antibody in these patients. And we discover a few patients each year that have a new diagnosis of atrophic gastritis. A hematologic evaluation is often indicated for these patients, especially if they have multifactorial anemia. I see patients that have chronic kidney disease, myelodysplastic syndrome, and GI blood loss, and I'm not sure which one is the primary driver of their anemia. So in these complex patients, often we manage them in consultation with a hematologist who may give adjunctive therapy such as erythropoietin, or they might also perform additional testing like a bone marrow biopsy to really figure out, does this patient have anemia primarily related to GI blood loss or primarily related to lack of production. And then finally, a family history of inflammatory bowel disease or celiac disease may be an indicator of one of these pathologies as the source of anemia. And then we go to deep enteroscopy, and that includes push enteroscopy. So if you have a pediatric colonoscope, then you should be able to do push enteroscopy, which has a really good diagnostic yield in these patients with negative EGD colon, and also in patients that have negative EG colon and negative video capsule. You can look for missed lesions in the upper GI tract, such as subtle angioectasias or Cameron's erosions, and then you can look for angioectasias in the duodenum and proximal jejunum. As a small bowel specialist, I find most of my angioectasias in the proximal jejunum or distal duodenum. So you can find these lesions and make a diagnosis and treat patients if you can do push enteroscopy. If you have access to device-assisted enteroscopy, we have 3 techniques currently: double balloon, single balloon, and spiral. And they have similar diagnostic yields because they're all able to reach the proximal and mid-jejunum where most of these angioectasias live. And then finally, there's intraoperative enteroscopy, which I have to rarely employ, maybe once every few years in patients that have a lesion that's out of reach of device-assisted enteroscopy. So this is single balloon enteroscopy, just to kind of show you the principle of small bowel pleating. We advance the enteroscope, and then we advance the overtube, advance the enteroscope again, and overtube again. We inflate the overtube, and then we straighten the duodenal C-lobe. It really does get that straight. Advance the enteroscope, deflate the balloon, and advance the overtube with the balloon. Inflate the balloon, and retract or reduce. And so this is the basic technique, and typically we can reach the proximal 2/3 of the small bowel with device-assisted enteroscopy by the upper route or anterograde route, and then the distal 1/3 by the retrograde route. These are the images you see under fluoroscopy, which we don't use as much, but this is an upper enteroscopy on the left where the duodenal C-loop is straightened, and we're making these counterclockwise turns. And then on the retrograde exam, we go around the colon and into the ileum, and again, make these retrograde counterclockwise turns through the small bowel to pleat the small bowel onto the overtube. So this table shows the different deep enteroscopy techniques. There's double balloon, single balloon, spiral, balloon-guided enteroscopy, which is basically a through-the-scope balloon or TTS balloon that helps grab the small bowel and pleat it, and push enteroscopy. And when you compare these technologies, look all the way at the bottom at the diagnostic yield, and it's about almost 60% for a lot of these different techniques. And the reason is because most of the pathology that we find is in the proximal and mid-jejunum and distal jejunum, and you can reach this area with all these different techniques. And also all these different techniques by the oral route are revealing for missed pathology in the upper GI tract. So when we do research studies and we find that we have a bleeding source such as a Cameron's erosion or angioectasia in the stomach, then that's included in the diagnostic yield. So the diagnostic yield for all these different techniques, including push enteroscopy, is fairly high, around 60%, even though they have different lengths of insertion or depth of insertion. So when we look at total enteroscopy rate, the ability to look at the entire small bowel, double balloon is superior at 34% on average, compared to single balloon and spiral, And then obviously push enteroscopy does not reach the colon from the mouth or by oral and retrograde approaches. When you look at procedure time, double balloon is longer because you're going further down the small bowel. So double balloon is a little bit longer and a little bit more cumbersome with 2 balloons. You see that on upper and lower approaches, so the procedure time is longer, but the total enteroscopy rate is higher. So double balloon is preferred if we're going to achieve total enteroscopy, but if that's your goal, but if your goal is to find a bleeding source, then the average diagnostic yield is similar amongst all these different technologies, including push enteroscopy, which again, you should all be able to do. Second look video capsule is often overlooked. So patients or gastroenterologists are used to doing repeat EGDs and colonoscopies in patients with a negative bleeding source or other complaints, but we kind of forget about second look capsule. Second look capsule has the ability to pick up typically an angioectasia. The diagnostic yield for second look capsule in patients over the age of 50 is about 33%, and we're identifying 1 or more small angioectasias that was missed on the previous study. And when I say missed, it just didn't take a picture of the lesion because it was hidden within a fold. So don't forget about second look video capsule as one of the studies you can use in a patient that's got a negative EGD colon capsule in the past and now has recurrent anemia. And then there's the last things are provocative testing. So provocative angiography is the use of systemic heparin and intra-arterial vasodilator and or thrombolytic. This technique has been proven to be beneficial primarily in lower GI bleeding from diverticulosis. And I can tell you from my experience with small bowel bleeding, people with small bowel bleeding are bleeding from often an angioectasia or duofold lesion, and the lesion is too small to see very well or embolize with angiography. But when patients have a large vessel that feeds a colonic diverticulum, that's when angiography and embolization is really beneficial. And that's when also provocative testing is mostly beneficial. This is the complete body of literature related to provocative angiography. And we typically quote the last few studies which show a diagnostic yield and therapeutic success yield of 26 to 50%, and the last 3 studies in 2010, 2014, and 2020. And these are all using intra-arterial thrombolytic and sometimes with systemic heparin. Their complications are rare, so it's relatively safe. And most of the time we are finding bleeding diverticulosis as the source and treating that lesion effectively. So provocative angiography can be considered in patients with obscure bleeding that's overt, but it tends to be more useful in patients with obscure overt bleeding from diverticulosis, which we certainly do encounter. And then there's provocative endoscopy, which I do, and we published a series in 2017 talking about our experience that we have ongoing at LSU. And we use antiplatelets or anticoagulants to stimulate bleeding when the bleeding source has been undefined. The goal is really to stimulate bleeding from an angioectasia or doulophoi rather than elicit bleeding from an unknown bleeding source. So we're not giving a blood thinner to stimulate bleeding and then try to figure out what it's from. We have a very fully evaluated patient that's got suspected bleeding from a specific focus that's been examined endoscopically, and we've examined an area and found blood in there previously by video capsule or balloon enteroscopy or colonoscopy or EGD. And now we're giving a blood thinner to elicit bleeding from a doulophoi lesion or an angiectasia in an area where we know essentially where they're bleeding from. So there's 3 different groups that we see. There's provocation experienced patients, which patients come to clinic and they say, every time I take clopidogrel, I bleed. And in those patients, we put them back on their agent. Typically, it's clopidogrel. And the diagnostic yield is typically fairly high at 53%. And we're finding always in these cases angioectasias and doulophoi lesions. And then there's naive patients that don't have that history. They've never taken clopidogrel or any other blood thinners, or they've taken them and not really had an associated complication or bleeding risk. So when we do these cases, the success rate is less. Generally, we're loading these patients with 300 milligrams of Plavix 12 or 16 hours prior to endoscopy, and that's typically prior to video capsule. And when we're finding lesions, we're again finding angioectasias and doulofoid lesions, which are not typically found or may not be found unless they're bleeding at the time of the procedure. And then there are cases of really difficult, overt, obscure GI bleeders where they have overt bleeding episodes, they bleed aggressively for 12 hours, they're transferred to the hospital or admitted. We do an evaluation, the bleeding stops, and then we don't know where the source was, and then it happens again and again. So some of these patients I've seen in this series have been admitted 10 or 15 or 20 times, and it's very frustrating for the patients and the physicians that care for the patients. And so in these patients, we may keep them in the hospital after a resolved bleeding episode and give them 300 milligrams of clopidogrel and a heparin infusion, and then do their video capsule and enteroscopy. And we're finding doulofoid lesions and angioectasias in most cases, but there are a couple cases where we found things that we did not expect, which was bleeding from the pancreas. And we found one carcinoid tumor that was missed on 2 video capsules and CT enterography. So this is a case of provocation where we have a bleeding source that's recurrent. I found a bleeding source, and then we're going to mark the area with India ink. I typically put a lot of ink, so it's easy to find later. And as you can see, this bleeding source would not be observed or discoverable unless it's actively bleeding at the time of the procedure. So there's basically no hope of finding this lesion unless it's bleeding. So I have to either luckily encounter the source when it's actively bleeding, or I have to stimulate bleeding. Now, in these cases, I tend to not just take them from home and thin their blood. These are patients that are seen in the hospital. I try to capture it during a spontaneous bleeding episode. And if they stop bleeding while they're in the hospital, I'll keep them in the hospital and then provoke bleeding the next day. Next slide. So lessons I've learned from doing these provocation studies over the last 10 years is that some bleeding sources may simulate bleeding from an AVM or an angioectasia, or simulate bleeding from a doulofoid lesion, even after negative EGD colonoscopy, video capsule, and CT. And that's typically a rare small bowel tumor, Meckel's diverticulum, aortoenteric fistula, hemocecus or hemophilia, and small bowel varices. So because of these pathologies, typically I recommend, or typically I require patients being considered for provocation have a standard CT scan of the abdomen pelvis with oral and IV contrast. And if they've never had that study, you may discover that they actually have a tumor in their pancreas or the liver, or they have cirrhosis in small bowel varices, or they have inflammation around the aorta or previous AAA repair, and that's the source of bleeding. So sometimes patients have had 10 EGDs, 10 colon, 3 video capsules, and all these different exams, but they've never had just a regular CAT scan of the abdomen pelvis. And then as far as emerging technologies, when I hear a talk on this topic, it's kind of boring because it's nothing new. So I'm trying to introduce something new. So something new that you may not know about is artificial intelligence with capsule endoscopy, which is evolving, and it's actually pretty good. So it's evolving. This is automated lesion detection, capsule localization, and bowel prep scoring. The automated lesion detection part is the most exciting part because the system is designed to identify angioectasias, tumors, ulcers, and other pathologies. And so it could potentially bring you to the lesion. And then if the artificial intelligence software reads the study as normal, it might show you a few images, but then read it for you. So it's got a ways to go, but this is an exciting change or exciting development in video capsule that would obviously decrease reading time and potentially increase diagnostic yield. Something that's also very exciting if you're a small bowel specialist is motorized spiral enteroscopy, or power spiral. They've had several recent studies that show a total enteroscopy rate of 70% compared to an average rate of 34% with double balloon and 12% with single balloon. The anterior grade insertion time is 26 minutes compared to, say, 80 minutes average with double balloon, and the retrograde insertion time is 17 minutes compared to, say, 80 minutes with lower double balloon, or 70 minutes. So the insertion time is lower, the enteroscopy rate is higher, and it's associated with a relatively high diagnostic yield. So spiral enteroscopy is in development, and it's been in development for quite a while, but it may be a real game changer in practices where you can pick up a spiral endoscope and step on the foot pedal and spin through the small bowel with relative ease in a relatively short period. And so we'll see. I'll be interested to see how this works out as far as when it comes out and who can use it. So this is the last slide to summarize our last couple slides. The definitions for suspected small bowel bleeding and obscure GI bleeding were updated in 2015. Now, obscure GI bleeding is GI bleeding which is undefined in source after negative EGD colon and video capsule. Video capsule is the next step in evaluation of bleeding after negative EGD colon. You should not be using small bowel follow-through. Patients over the age of 50 who have resolution of bleeding and negative EGD colon capsule can be managed expectantly. You may be uncomfortable with this, but this is the guideline recommendation, and I would agree with this. If their anemia resolves with iron, you did not find the bleeding source, and that's okay. If it's a patient younger than age 50, then something's wrong. They have a tumor or a Meckel's or something. They don't have an Angioectasia very often, and so they need additional testing. And patients that are over the age of 50 and their anemia recurs, which will be maybe half or 2/3 of patients, then go back and do additional testing, typically another EGD colon capsule, kind of depending on the case, or you could go to push enteroscopy next. I appreciate your attention, and I'm sorry for the interruption around slide 7. I'm going to hand it back over to Christina, who's going to field some of the questions from the group, and I will answer and turn back on my webcam.
Thank you, Dr. Rains, for a most informative presentation. I would like to tell everyone how to get their certificate of completion. So continuing education for nurses and physicians, again, it's been approved for 1 contact hour. To obtain your CE credits, you'll go to www.saxtesting.com/INIT. You'll need to register at the site, complete the evaluation, and then upon successful completion, you'll be able to print your certificate. And then the archive version or the on-demand version will be available at www.initiative-patientsafety.org. An email will be sent to all the attendees when it's available, and the on-demand version will also be accredited for physicians and nurses. And we'll go ahead and get into our questions, Dr. Rains. We have some really great questions that have come in, so we'll go ahead and go through some of them. With balloon enteroscopy, do the patients have an increased risk for intestinal volvulus?
It's pretty rare. I've done 2,000 procedures and we've never seen that happen, but it is a reported complication, but really extremely rare.
Great, thank you. Can you chat about banded ligation versus embolization for esophageal varices? Do you feel esophageal balloons are helpful?
That's a separate topic in small bowel bleeding, but the standard of care for treatment of esophageal varices is esophageal banding and medical therapy. We use sometimes balloon or Blakemore tubes with balloons to tamponade varices in the acute setting, but that's kind of rarely used. So for treatment of esophageal varices, then we use esophageal band ligation.
And what is your decision-making process for when to use a balloon enteroscopy versus another diagnostic modality, such as a second lobe capsule? I know you sort of touched on this, but just to reiterate this.
Yeah, it depends on the patient's comorbidities. So patients that are, obviously, older and they might not tolerate a balloon enteroscopy, then we might go to a second lobe video capsule next. And so it depends mostly on the patient's kind of age and risk factors for endoscopy. Patients that are high risk for endoscopy, that are older and have comorbidities, we would tend to do a second look video capsule. And patients that are healthier, then we would do probably an upper enteroscopy or push enteroscopy. Great,
thank you. What is your approach to managing patients after you identified the bleeding source during the provocation?
We just do endoscopic therapy. So APC, or argon plasma coagulation, is safe in patients that are anticoagulated. And then you can also use hemoclips. So for the typical bleeding sources that we find, which are angioectasias and doulofoid lesions, we treat those patients with APC and hemoclips, and that's safe and considered safe and effective per the guideline.
Thank you. Using these modalities to evaluate small bowel bleeding, have you seen a significant decrease in readmissions, impact on patient care and follow-up?
We haven't done any prospective studies on comparison of like a control population, so I can't speak to that as far as an objective change in a population or a group. I can only speak to individual patients that come with kind of continued bleeding, and I'm trying to change an individual patient course. So to convert a patient from recurrent overt bleeding to not bleeding anymore, or a patient that's got multiple Angioectasias to convert them from a blood transfusion every month to a blood transfusion every year.
Okay. Sounds like it's making a difference then. Other than PPIs, are there any other medications you like to use for small bowel bleeds, obviously besides iron?
Yes, I'm glad you asked that question. So PPI therapy is not really a medical therapy that I use just for small bowel bleeding. And a lot of the small bowel bleeding I see is Angioectasias. When we speak specifically about small bowel bleeding from small bowel Angioectasias, medical therapy with octreotide is the standard of care typically. And it's a depot injection once a month with depot octreotide. For insurance authorization, this should be prescribed in a hospital infusion center, so it's covered under their Part B benefit. If you send it to the pharmacy, then the copay will be high. So it's an obstruction or barrier to treatment. There are a bunch of other drugs that have been studied. My anecdotal use is tranexamic acid, which I might use after octreotide therapy, and that's 650 oral pill twice a day. There's probably 12 other drugs that have been studied for small bowel bleeding from Angioectasias in the setting of patients with bleeding from the small bowel, as well as patients with bleeding epistaxis in the ENT literature. So the answer to your question is endoscopic therapy, iron therapy, including parenteral iron, and octreotide is typically those three interventions.
Perfect. Thank you. After angioectasias, what are the other most common sources that you typically see? I know it kind of varies based on age, but I'll let you take reins on that.
It's a big mix. So angioectasias in patients over the age 50 are most common, and then it's a blend of a few patients with Crohn's, a few patients with enteropathy, a few patients with atrophic gastritis, celiac disease, Meckel's, tumors, bleeding from, say, daily hemorrhoidal bleeding or something unusual. So you really have to, I can't give you a percentage or a quote as far as like what's after. And then in my experience, it's just a few patients in each bucket. And so I have to go through and look for those individual diagnoses for those individual cases.
And then we have a follow-up question. When are PPIs used then? We give them in the hospital after every GI bleed and send the patients home on them.
Yeah, so I think that, PPIs are effective in stabilizing clots in the stomach. So PPIs are given for GI bleeding because a low pH promotes pepsinogen conversion of pepsin, and then the enzyme pepsin digests blood clots. A low pH also inhibits platelet aggregation. And so bleeding from the stomach is treated with PPI therapy. The acid from your stomach is neutralized in your duodenum by your Brunner's glands. So when you're bleeding in your proximal small bowel, your pH is normal. So on PPI or not. So we don't use PPIs to treat or lower the pH or change the pH in patients' small bowel because your body does that all by itself. So you're not really benefiting a patient by giving them a PPI in a patient with small bowel bleeding because their pH is normal in small bowel bleeding.
And what is the likelihood of perforation during enteroscopy, just in your experience?
Sure. So the quoted rate of complication is about it's really 1%, depending on the study you read. And that's typically for polypectomy. So when we're removing large polyps, the perforation rate's relatively high, are 1%. And then in the diagnostic studies, it's typically like 1 in 3,000. So the perforation rate is kind of similar to colonoscopy. So this fancy procedure, it's really not that fancy. It's just the equipment that we use for device-assisted enteroscopy is just not that widely available. and not that many people are trained. So often it's kind of discussed as like this fancy or advanced procedure or difficult or therapeutic procedure, but it's really not. It's just not commonly performed. But the risks are similar to, say, like a colonoscopy, and in somebody that's got experience with the exam.
Sure. Thank you. And how often do you personally end up doing a repeat capsule endoscopy?
A lot. Because most of the people I see come with a negative EGD colon capsule, or they come with a negative EGD colon and then they have a bleeding source on their video capsule. So fairly commonly, and it's commonly approved by insurance. So in years past, 5 or 10 years ago, it would be hard to get the insurance company to approve it, but now it's fairly readily approved. So we see also that in the community. So second look video capsule has a fairly good diagnostic yield, and it doesn't have any risk with it. So that's something that should not be overlooked.
Perfect. And then that leads me into just one other question. Just to review, what sort of patients wouldn't be candidates for video capsule endoscopy?
Generally, I consider those patients that say they can't swallow. So some people are elderly and they can't swallow a big pill, or patients that have suspected small bowel obstruction. And those are patients with either small bowel obstruction as their presentation, or they have Crohn's disease with obstructive symptoms. They can drop dummy capsules or sugar pills, basically, or placebo pills, to evaluate for retention of those in anticipation of a video capsule. And then there's this group of patients that have implanted devices like a cardiac device. And then in those patients, there is a concern about interference of the device with the video capsule transmission rather than vice versa. So maybe the video capsule wouldn't obtain images very well, but that's not going to hurt the patient. So in my personal experience, I do video capsule with pacemakers, defibrillators, and I have really not a second thought about it. But because to demonstrate that that's safe, or demonstrate there's no interference, then there would have to be really thousands of patients examined with thousands of devices to demonstrate that there's no interference, and that's just not feasible. So in my practice, I don't consider that a barrier, but some people may consider that a barrier, but I don't personally.
Thank you. And do you personally perform the spiral enteroscopy, or have you seen good success with this?
I personally perform spiral enteroscopy with a spiral overtube, but I don't have a power spiral yet. Some of my friends have power spirals that they're participating in the trials. So it is very exciting, and I have heard reports of how quickly they can examine the small bowel. So it's been studied for years now, probably 12 years. But we're still waiting for the actual release, and so I'm not sure when that will be, but we'll see.
Sure, thank you. And since we've talked a lot about iron, what are your favorite iron preparations, and how often do you use IV iron in a patient?
Yeah, I'm glad you asked that question. So I'm very aggressive with parenteral iron. So I typically use Injectafer 550 in 2 doses every 3 months or 6 months or yearly. Often the patients that I see, they don't need endoscopic ablation of their Angioectasias. They just need a dose of parenteral iron. It's fairly difficult to absorb oral iron. You typically absorb the same amount of oral iron if you take it either daily or every other day, compared to twice a day or 3 times a day. So as gastroenterologists, often we're not well versed in iron supplementation. We'll give patients 2-3 doses of iron every day. It doesn't really make a difference compared to once a day or even once every other day. And those patients that have still severe iron deficiency and anemia on oral iron, they really need parenteral iron. And often I'll tell patients that if they have chronic GI blood loss from Angioectasias, especially, we're not curing their blood loss, we're managing it. We're going to manage it with iron therapy once every 6 months or once a year, and then endoscopic ablation every 1 or 2 or 3 years, depending on their need.
Perfect. Thank you. Great answer. And I know you touched upon this in your presentation, but is there still a place for other imaging modalities in small bowel bleeding?
Sure. There's a place for CT enterography. and MR enterography, which are non-invasive. There's a place for Meckel scan, and that's also non-invasive and relatively easy to do. So there are places for imaging studies, but just not small bowel follow through. It's outdated, and physicians or practitioners that have used small bowel follow through in the past, it's kind of hard to drop something that you're so used to using, but that needs to be dropped.
Perfect.
Because the diagnostic field is so low. Yeah.
Certainly. And I think we have time for one more question. And do you order the multi-phase CT in the community setting? I know you talked about it in the research setting, or had success, I guess.
Yeah. So when you order it in the community setting, if you have a CAT scanner, you can do this study. But the radiologist or the imaging center is going to say, well, how do we do that? And the answer is they have IV contrast. Typically, it's IV contrast and non-con, and you can do a delayed, and it'd be preferred to do a delayed. So at least 3 phases. And then when they do the exam, they don't give them oral contrast; they give them oral milk. So it's half a gallon milk, and the timing is just like oral contrast. And then they would do 2.5 millimeter sections instead of 5 millimeter, which is standard. And with the in addition to the 2.5 millimeter sections, they should do reconstructions, axial, sagittal, and coronal reconstructions. So there's multiple reconstructions with multiple phases of contrast, which generates a lot of images, which might detect a small bowel tumor, but it's not just a regular CAT scan.
Sure. Okay. Well, thanks for sharing that. And I think we are nearing the end. So thank you for answering those questions. And I will turn it back over to Tracy.
Thank you, Christina, and thank you, Dr. Rains, for such a fabulous presentation today. We also like to remind everyone that today, immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we do appreciate your feedback, as well as the CE Certificate of Completion. To obtain your CE credits, please visit www.saxtesting.com/INIT and register at the site and complete your evaluation. Again, we'd like to thank Dr. Rains for his presentation today, as well as for everyone that has attended today's webinar. And we wish everyone a pleasant rest of the day. Thank you.